Welcome to the audience. Welcome to this Impact webinar on implementation science organized in Switzerland. I'm Marie Schneider, Professor of Medication Adherence and Interprofessionality at the University of Geneva in Switzerland. And I'm chairing this session today on behalf of Professor Sabina De Guest, who is with us today, but she's traveling at the moment, so she cannot share the webinar. Welcome to everybody. It's a great pleasure to have you here today. The audience is from all over the world. I've seen people coming from several countries in Europe, North Europe, Denmark, Norway, of course, Switzerland, but also the US, Canada, Brazil, people from Belgium, from Holland, the UK, people from Ghana, from Ethiopia, from India, from Ireland, Italy, Lebanon, Mexico, etc., etc. So a huge audience for welcoming Professor Pinnock today. I'm going to introduce you. So Hilary Pinnock is Professor of Primary Care Respiratory Medicine at the University of Edinburgh and a family doctor in Whitstable, Kent. So I looked on the map to find Whitstable, and it's on the coast, southeast of London, and it seems to be facing Belgium and Netherlands. So Hilary Pinnock, she leads the programs of work in the Asthma UK Centre for Applied Research and the Respire Global Health Research Unit on Respiratory Health of the National Institute for Health and Care Research. Her research interests include the delivery of care within the real-life primary care setting, including implementing supported self-management for asthma, remote consulting and telehealth for respiratory disease, talking therapies to help people with COPD and depression, and supportive care for people with severe COPD. Professor Pinnock is chair-elect of the Education Council of the European Respiratory Society, and she's actively involved with the International Primary Care Respiratory Group and the UK Primary Care Respiratory Society. She has been a member of the British Asthma Guideline Development Group linked to the British Thoracic Society and Scottish Guidelines Networks, and she is an associate editor of NPJ Primary Care Respiratory Medicines. It's a huge honor to have you here with us today, Professor Pinnock, and you are going to give us a talk about implementation research for real-world change in primary care. Professor Pinnock, the floor is yours.
Thank you. Thank you very much, and I will share my screen. But thank you for that very kind welcome, and I'm really impressed to hear how far afield your webinars go from around the world. Let's see if I can make this share my screen. Here we go. You should see my PowerPoint now, and I will set it going. So hopefully you can all see that now. So thank you very much indeed for the welcome. As I say, as I was introduced, yes, I am a primary care physician, and that's of course where my interest in implementation research has come from, because as a clinician, I see the need to implement guidelines. I read guidelines. I've been involved in developing guidelines, and we all know how long it takes to get a guideline recommendation into clinical practice. So it's that has really what has fueled my interest in the science of how we get things to work and make change in real life practice, not just in primary care actually, but really across our healthcare systems. So, okay. I have no conflicts of interest that are really relevant to this presentation apart from my enthusiasm for the topic. I'm not going to be talking about any specific drugs or treatments. What I wanted to do was to start by positioning implementation research in the context of a research agenda. And I'll spend a little bit of time talking about translational gaps and where implementation research fits. Then I want to look at a couple of exemplars of implementation science that I've been involved with. And along the way, I'm going to talk about some of the challenges that we face in implementation research. So, you'll be familiar with translational gaps. Most people, if you talk about translational gaps, will say, oh yes, T1, T2 translational gaps. That makes sense to people. So T1 gap is the gap between the basic science, when you begin to wonder if the chemical that you've discovered or the physiological activity that you've discovered can be actually used to develop insights that could help clinical practice. So this is where the first in human studies fit, for example, phase 1 trials that show whether a drug actually can even get into the system, and all the classic things that you have to look for. Is it potentially going to be a useful clinical product? Then moving on to the T2 gap is when you start to say, okay, so I've got an active compound, I've got a modality, perhaps an exercise program that seems to be able to do something, but now I need to look at and see whether that is actually going to be useful in clinical practice. So that's where the phase 2 and the phase 3 clinical trials come in, as new interventions are tested under really controlled environments to form, and they therefore form the basis for evidence-based guidelines. What people rarely think about, I think, is that actually that is only halfway through the story, because you may have a drug that works, you may have an intervention that actually works, but how do you put that into practice? And the next gap is horrifically something like 17 years on average between a new intervention being shown to be effective and actually getting into routine clinical practice. So this next gap is around how does it work? Not under ideal circumstances, but under the typical circumstances in which I work and the patients that I look after. How can I make it work in my clinical practice? So this is where the implementation research starts to fit in. And then there is even one more gap beyond that, because even when we've shown how we can actually deliver something in our clinical practice, how do we sustain that so that we can actually improve the health of the population? So then we are looking really at population and public health level interventions. So we've got these 4 gaps, and if you want to look up more about them, I've given you the website. It's the Harvard Catalyst, and if you Google that and write Pathfinder in, you'll come up with a lot more information about those translational gaps. Summing them up in a different way, it's not enough to show that an intervention can work under ideal conditions, as for example in a trial. We need the implementation question that we need to ask is, will it work? Or can I adapt it so that it will work in my setting? And the methodology for doing that has to bridge these different gaps, and it evolves. It's a spectrum across these different gaps. So at the beginning here with the T1 gap, we'd be looking at potentially 1, 2, 3 first in human studies, usually men. Or often men, because we don't want to risk a woman being pregnant and giving a drug or something of that sort. So often men, usually fit, no other problems, and often the outcomes you're measuring are physiological, a blood test or lung function or such. Then when you start to want to see if it's going to work in clinical practice, you recruit a few people who fit your careful, ideal patient. So, for example, if you were testing a drug, you'd need people who were adherent to taking drugs. That's a small proportion of the people I look after. But they reckon about 5 to 10% of people who, in a condition like asthma, who are eligible for trials, only about 5 or 10% of the total population of people with asthma would be eligible. So here you have a very carefully controlled trial. The doctor who's dealing with this patient here in this trial has no room for manoeuvre. Her role here is to assess the safety and the outcomes for the patient, and her only decision is it safe for this patient to continue or should they stop? She's unlikely to have any ability to change any treatment. when you move into translating that into clinical practice, of course, we have to start thinking about a very broad range of patients, the young, the older, the people with multimorbidity. And now, if you're running a trial in this T3 gap, you're starting to give the clinician will have a bit more room within the guidelines of the trial, of course, but will have room to adapt, perhaps according to guidelines, adjust treatment, or indeed manage the multimorbidity. And the outcomes that we're going to be interested in now are health service outcomes, reducing attacks, reducing hospitalisation, patient-reported outcomes, improved quality of life or reduced symptom scores. And then, of course, we need to start thinking about translating into populations. And the classic example of that, of course, was the COVID vaccine, where we moved through all these stages really very quickly in order to get the vaccine out there. And a lot of the evidence was then gained in terms of using routine data across whole populations. So population statistics and big data become important at this stage. And the context in which this is being implemented becomes increasingly important as you move from T3, T4. The context becomes absolutely crucial. Important to point out that this is a spectrum. One of the dangers of this type of model is it looks as though they're categories. Well, they are slightly categories, but actually they're a spectrum, and some studies will fit between the two, and exactly where you fit on that spectrum will depend on your research question. Another way of looking at this, and many of you will be familiar with the Medical Research Council, that's the UK Medical Research Council, who many years ago now started publishing frameworks for developing and evaluating complex interventions. These are the references for the most recent versions of this. And basically what that says is that if you want to develop a complex intervention, and actually a lot of interventions are complex, even apparently quite straightforward things like taking tablets, when it comes to the patient's perspective, can be quite complex. You need to develop the intervention, you need to get the background work, understand the theory behind it, develop an intervention, feasibility test it, refine it, pilot it, and then you're ready to undertake an RCT, a randomized controlled trial, in order to assess its effectiveness. Then, when you've got your results, you disseminate those in the hope that that will change practice. But as we know, it doesn't work like that. And I'm going to give you a couple of examples of how we thought through this problem. 17 years it takes to change practice. So we need more work to think about that, and that's where implementation science comes in. That's where we need to think, and I would suggest we need to think in terms of another cycle as we develop an implementation strategy. We need to develop that implementation strategy using evidence-based theoretical underpinning, test the feasibility of the components of the strategy, pilot it, and then evaluate it. Often, but not necessarily, in a randomized controlled trial. With implementation sciences, there are other models that may be better. And even then, we're not really finished, because we need to think about sustainability. It's all very well implementing something, but you actually need to work out how it's going to be sustained within clinical practice. Now, these two definitions that I've already alluded to, really, the intervention, that's the evidence-based intervention that we want to implement, the change that we want to make, and the implementation strategy, which are the evidence-based strategies that we can use in order to promote implementation of that intervention. These are two really crucial distinctions. And if you remember nothing else, I suggest that that's probably the key point that I want to make. Think about those two as distinct. We worked through this when we developed the STARI reporting standards, that's standards for reporting implementation science. And when we were working on this, we realised that we needed to distinguish these two very, very clearly. And if you look at those reporting standards, this is like a consort checklist, but it's actually the big key feature of it is that it's divided into two columns. So we've got a column for the intervention and a column for the implementation strategy. And often you have to answer and describe both of those. So the scientific background for the intervention and the rationale for the implementation strategy both need to be described. I'm not going to go through all of these, but you can see how going through the characteristics of the site where you're going to implement the intervention, but also the description of the intervention needs to be clearly described. And the same applies to the results and the discussion. So many different models of methodology may apply to this, but the key issue here is think in terms of those two categories. Another way of looking at this, which we designed for the STARI guidelines, if you've got an implementation strategy, you need to think about implementation outcomes. They have to follow that. So, and I'll give you an example in a second. But the implementation strategy, the success of that is measured by an implementation outcome. You're implementing a health intervention, and the outcome from that is measured with a health outcome. There will be other outcomes. You'll almost certainly want a health economic evaluation. You'll almost certainly want quite a complex process evaluation in order to understand the acceptability and how people adopted and adapted the intervention. So all of this will need to be built into this, and you will need to understand the context and how the context changes during the course of the study. To give you an example, we have had some recent evidence in the respiratory world about smart inhalers that improve adherence and indeed improve outcomes for patients. It's published as a Cochrane review. So maybe you wanted to say, I want to implement that. How would you go about? What strategies might you use? Well, you might, if you were a policymaker or a management, you might say, well, okay, we'll fund this. We will make sure that the inhalers are available, time is made available, and time is money. We'll fund that. Now, if you funded that, that's your implementation strategy. The outcome might well be how many smart inhalers were actually used, perhaps in a specialist asthma clinic, how many. You could count the number of prescriptions that were done. So that might be your implementation outcome. Your health outcome, on the other hand, would be related to the patient, how many attacks they have. Can you see how you've got two different strands going through? And its distinction is not only helpful for academics. As a healthcare professional, if you're trying to implement something in your practice, I think it's good practice to think, what am I trying to, what is the intervention and the evidence for it, and what are the strategies that I'm going to use in order to implement it? So that, I hope, puts implementation research into a context. I now want to move on to a couple of examples of implementation and the challenges that we had, which will, I hope, give some examples of what I've been talking about. The first example I'm going to give is around home monitoring for hypertension. I'm interested in supported self-management. And this all comes from some work that I started off many years ago, looking at supported self-management, particularly for asthma, but we also looked at other long-term conditions, including hypertension. Now, this is the classic management strategy for somebody with high blood pressure. It's asymptomatic, so the patient has to come in every 3-6 months, and the clinician will take the blood pressure and then provide the advice on the treatment that's required. And all the patient has to do is turn up every few months and take the tablets they're asked to take. So that, if you like, is the traditional model. It's quite labour intensive for the clinicians, and the patient is really left just, I was going to say, doing what they're told, or often, of course, as we know, choosing not to. So we looked at home monitoring as one of the strategies for supporting self-management. PRISMS is a very large systematic meta-reviews that we carried out 15 years ago now. We started this project, and we covered a lot of 14 different long-term conditions as to how they could be, how they could work in clinical practice. So we were looking at the methodologies behind how we did this, and the type of systematic, the type of supported self-management that worked in hypertension. Now, this was a systematic meta-review. Just need to explain that is not the same as a systematic review. What we're doing here is taking systematic reviews and synthesizing the findings of the systematic reviews. So in this case, we had 6 qualitative systematic reviews, and that included data from 98 qualitative studies, and we synthesized those systematic reviews. Similarly, for the quantitative studies, we were actually had 29 systematic reviews, but they included data from nearly 450 quantitative studies. So that's the volume of data behind it. Looking at the qualitative data first, we had two themes that came out from all these qualitative studies. What patients believed about their blood pressure and how that influenced whether they chose or chose not to take their drug treatment, and then how the relationship between the clinician and the patient worked, and that's where the home blood pressure monitoring came in. In terms of understanding their disease, clinicians believe that blood pressure doesn't cause any symptoms. It's an asymptomatic condition. Patients, however, don't all agree with that. Many patients believe that their blood pressure causes them to have headaches or makes them feel tired. And indeed, some patients were in this qualitative work were actually adjusting their treatment according to their symptoms. So if they had a headache, they believed they needed to take their treatment, and if they were feeling very well, they didn't. So there were patients who were actually adjusting their treatment on the basis of whether or not they had symptoms that as a clinician I don't actually believe are related to the blood pressure. When we looked at the trials, they also focused on the issues of adherence and encouraging patients to take their treatment regularly, and how home blood pressure monitoring could actually improve that. So here's the result of the quantitative data. Remember, these are the summary statistics from systematic reviews. You can't do any further analysis on those. So we're just displaying them here. And as you can see, systolic and diastolic blood pressure improved in just about all the systematic reviews. So it would appear to be effective when patients had self-monitoring, had a sphygmomanometer at home and monitored their own treatment. And the reason that we felt this worked, reading the qualitative data as well, was that it was fostering what we call a therapeutic alliance. Now, instead of trying to treat their symptoms, patients were treating their blood pressure. They were doing the same thing as we were. As clinicians, they were treating their blood pressure, and it gave patients a sense of control over what they're doing. So that seemed to be the mechanism by which it was working. Now, telemonitoring is one of my interests, and here I'm working with the Telescott group led by Brian McKinstry, a colleague in Edinburgh. And quite obviously, telemonitoring is one way of supporting people to self-monitor. This is a trial where he randomized individuals. It's really at the T2 gap. And he randomized 400 patients with uncontrolled blood pressure, and one group were treated in the usual way, and the other group had home monitoring, which then linked to the GP practice, who could then see the blood pressure readings and provide advice accordingly. And what we showed was that this type of telemonitoring with home blood pressure control reduced the blood pressure compared to controls. Now, 4 millimeters in drop in systolic blood pressure may not sound very much, but if you do that over a population, the reduction in complications is really quite significant. And because of that, it was a cost-effective trial, just because of the reduced cardiovascular complications, the number of strokes that would have been prevented. And the patients, with our qualitative work, the patients liked doing it. They found it convenient, and the healthcare professionals appreciated it. They thought it was a good approach. So we had all the evidence that we had an intervention that needed to be implemented. The question then is, are we ready to implement it? And what were the questions? Well, the second key message that I'd like you to take away is, when you're thinking about this, what the questions are, think about it from the perspective of the patient, the clinician, the organisation that they're working in, and the policy, the national policy. And when we started to do that, we found lots of questions that needed to be thought about. the convenience, preferences, how are we going to give feedback to the patients? Could they afford it? Were there going to be problems there with affording? What would be the uptake? How many of our patients, not just in a trial, but how many of patients in real life would be interested to do this? The clinicians have their preferences. Are they going to be paid to do this? Is there going to be time within their day? Because there was time. It did take time, particularly the setup time. So was there to be reimbursement? Were they going to, some countries you're reimbursed by actually seeing patients face to face, but not by any other means. Well, that's a major disincentive to somebody, to a professional who wants to implement telehealth. What about the organisation? How's it going to work? What infrastructure do you need? Is your IT connections good enough? What are the information governance issues that need to be considered? How is this going to fit into the routines? And then, of course, there's the policy. Incentive, costs, who's paid? Is this going to increase inequities? What can you do to prevent that? So lots and lots of questions that need to come into play if you want to implement this. So this is the questions and some of our answers. This is some of the solutions, the implementation strategies that we put in place in order to overcome some of these things. Lack of confidence in IT skills is important, not just for patients, but also for professionals. Some professionals do not feel comfortable with IT any more than the patients do. So ensuring that there was training and helplines that could help people who, whether they were patients or professionals, help them to, because once they understood how to do it, that was fine, but the lack of confidence is important. Now, in the trial, the clinicians had a separate login. They had a password and they had a login, and there was a lovely feedback system online, but they had to log in to do it, and that was completely unacceptable in routine clinical practice. So we had a system that we developed which sent the feedback to the clinician via what we call DocMan. Now, DocMan is an add-on to our clinical systems, which presents to us the letters that are coming into the practice. So we arranged for the technology company. They weren't frightfully pleased because they liked their website, but we arranged for them to produce a PDF of the results from a given patient, and it was sent back as a PDF, just as if it was a letter coming into the practice. So as a clinician who went through their letters every day, this just appeared in with the letters. They also made sure that the really important information is in red and up at the top so that you really can't miss it. So this meant the clinician didn't have to change their routines. They didn't have to do anything different. They just got this at whatever interval they set. So if they wanted to see it monthly, it came in monthly. If they wanted it 6 monthly, they got a 6 monthly report. So it was customized by the clinician. Initial registration proved to be extremely time consuming, and if, like we do, we only have 10-minute consultations, if the registration process takes 12.5 minutes, which it did, that was impossible. So the NHS Lothian funded some support to enable that. They provided some healthcare assistants who could do some of the registration and funded that initial process. There was concern about increasing inequities, and NHS Lothian provided the equipment for everybody, so that there was no issue about can't afford a blood pressure machine. One of the issues that we found was that because it was coming in on information on DocMan, the clinician used their normal responses, and their list of normal responses included, for example, come and see me. So where they would get a telehealth report and they think, oh dear, need to speak to that patient, there was nothing on that enabled them to speak to the patient apart from saying, come and see me. So the patient was then being called in for a visit, which rather negates the benefits of telehealth. So we had to set up and help them to support the idea of asynchronous consulting, so that they could either send an email and have an email conversation if it was just around changing a drug or something. So this was another step that needed to be built in. We made it flexible because patients are all different, and the review regimes needed to be customised by the clinician for that individual patient. And we needed an awareness campaign that encouraged uptake, and that's where I came into this, because I posed for the picture here, and I think that picture was displayed in every GP surgery in Lothian during the course of this initiative. And the outcomes from this, because we recruited no patients in this, we recruited practices, we didn't recruit patients. The practices offered it to any patients who wanted it that were eligible. So our outcomes had to come from routine data, one of the other hallmarks of implementation research. So what were the outcomes? Well, a really high proportion of practices in Lothian signed up over the course of a couple of years. 75 out of 126 practices is really a very good response rate, and it accelerated. It started slowly with the early adopters and then accelerated. They varied in how many patients that they recruited. But what was clearly happening is that this is the number of patients that were recruited, 3,200, and still increasing. As you can see, that's something of an exponential curve. The patients loved it. Why go to the surgery when I can do my blood pressure at home? And the clinicians saw it as a really helpful way forward. So it worked for everybody. And in terms of the health out of the implementation outcomes, in terms of the health outcomes, routine data from 8 of the practices, we were able to look at the blood pressure reading from the patients who were doing the telemonitoring. And this is the blood pressure reading, which, as you can see, is going down by about 5-6 millimeters of mercury. That's the systolic blood pressure there. So there seemed to be evidence, observational evidence, that we were improving blood pressure. And why? Well, the patients, this one patient couldn't bear to look at that slightly high blood pressure reading, just needed to do something about it. So it encouraged the patients to take action, and more prescriptions per year. So there was an increase in the number of prescriptions per year, suggesting an improved adherence. Though, of course, whether that was adherence by the patient taking the drugs or also adherence by the professional who was actually prescribing, now that they were working more closely with the patient. So that was my first example. My second example comes from asthma and supported self-management of asthma. So asthma is a variable condition by definition. People with asthma may be fine, something triggers them and they have an attack. It is by definition a variable condition, and it is therefore essential that everybody with asthma knows what to do if something goes wrong. Or to put that in terms of the guidelines, should be offered self-management education, which includes a written action plan and be supported by regular professional review. And what that comes to is knowing what to do if. These are action plans from a range of different countries, and they're all very similar in the sense that they all give the same type of advice. And as you can see, many of them will adopt the colour coding of traffic lights. So things are either good, keep with your current treatment; yellow, things are slipping a bit, maybe adjust your treatment; and red, there's a problem, this is what you do. So it's what to do if. And we know that those plans, we know exactly what they should contain. They need to have some form of symptoms or peak flow. It doesn't actually matter. You don't have to do peak flows, but you do need to recognise when things are going wrong. You need action points between 2 and 4 seems to be the optimum number. That should include increasing your preventers and when to start emergency treatment. And absolutely crucially, because asthma deaths do happen, when to seek medical help when it's becoming too serious. So we know what needs to be done. The evidence is overwhelming. We showed that in this meta-review. This again is back to the PRISMS meta-review, where we synthesised the evidence from 27 systematic reviews. That's 270 randomised trials. I'm just going to show you some of the data from that. This is hospitalizations, so anything on the left of that line was favouring the self-management group. These are the summary statistics from some large systematic reviews. And whether you're talking about hospitalizations, A&E attendances, or unscheduled care in primary care, whatever you're talking about, whatever you look at, supported self-management improves outcomes. Now, the first recommendations from guidelines were about 33 years ago, when the British Thoracic Society published the first asthma guidelines. Actually, some of the first guidelines in the world certainly in asthma, but I think they were one of the first in any condition. They were actually 3 pages long in the British Medical Journal. They made this statement. A lot of that guideline is actually devoted to working with patients, and the statement about, as far as possible, patients should be trained to manage their own treatment rather than being required to consult their doctor, comes from that original guideline. So that's 33 years ago. Since then, we've had generations of guidelines have been updated, and the statement, which I've always read out to you once before, about all people with asthma should have a written action plan and be supported by regular review. Sorry, click the wrong way. I could have used GINA guidelines, the global guidelines. I could have used guidelines from almost any other country because they all say pretty much the same thing. That was 30 years ago. When we looked, when we were starting the programme of work I'm going to tell you about, when we looked at the UK figures, this had just been published by Asthma UK. Now, Asthma UK is a charity, and they'd done a survey. They reckoned that 30% of people who responded to their survey said, I've got an action plan. Asthma UK have been very, very much behind action plans for many, many years. I strongly suspect that the people who respond to their surveys are particularly likely to have an action plan, because when we looked in clinical records, we reckoned it was about 6% had some evidence of a self-management discussion recorded in the clinical record. So the truth is probably somewhere between the two. I want to point out one other thing. The figures here are the 4 nations within the UK, mostly around about a third. But you will notice that Northern Ireland has a figure that's twice that, 63% ownership of action plans, which is interesting because, and this comes to context and implementation strategies, because in Northern Ireland they'd had a locally enhanced service that rewarded and reimbursed practices for providing additional care for people with asthma, including provision of an action plan. So just illustrating very simply, I think, the importance of the context and getting these strategies right. Within the PRISM's work, we also did a systematic review of implementation studies. I've given you the reference there. We found 18 studies that had explicitly implemented self-management, some in relatively small populations within a clinic, others within countries or cities. So a very broad range of studies. And if you're interested in methodology, you'll find some of the methodological challenges that we had with that, I think, quite interesting, and how we tried to overcome the fact that we had a very broad range of methodology to synthesize. What we concluded was that supported self-management can be implemented effectively in routine care, but you need to think of 3 things. And this is back to my point I was making earlier. You need to think about what you need to do to actively engage patients, what you need to do to train and motivate the professionals, and how can you support the organisation to prioritise and proactively support self-management. Because if the organisation does not believe in supported self-management, doesn't support it, then you can train professionals as much as you like, but they won't have the space and the opportunity to do that. And then was born our IMPART study, that's implementing improved asthma self-management as routine, in which we have put together an implementation strategy, which we have developed, piloted, and are now evaluating in a UK-wide cluster randomised trial to understand how we can implement supported self-management as normal care within primary care practices. And we looked at these 3 components. What did patients need? They needed information, they needed action plans. And what we did was we pulled these together on what we called our Living with Asthma website, where clinicians and patients can actually find the information that they want and the support that they need. we need to write letters when we invite people in for a review for their asthma. Many people don't attend. It's one of the, people come to their diabetic clinics, but they don't come to asthma clinics so readily. So how do we change that letter? And we worked with health psychologists to get a letter that encouraged patients and motivated patients to actually come for their asthma review. We had to think about different modes of consultation because we were developing all of this just before the pandemic hit. We'd sort of assumed that patients were going to be coming into the practice, and it became clear that they absolutely were not. So all of a sudden we were having to do everything remotely. So we had to think about how we could deliver supported self-management remotely. The picture at the bottom left here of the screen with the action plan in the middle is a medical student who did a little bit of technology work and showed that with the video conferencing software that we were using in the NHS, it is possible to share a screen. The patient can't actually do anything on the screen, but they can see what the clinician's doing. You can fill in an asthma action plan with a patient on the screen, and by sharing your screen with them. We had to think about what patients needed regarding the pandemic. All of a sudden, the information that we needed information that helped people with asthma who were obviously worried by the pandemic and the possible risks to them because they had asthma and what they could do to reduce those risks. We also added some extra in the last year or so. We've added some information about climate change. You'll be aware of the concerns about metered dose inhalers and depleting ozone layers. And a lot of patients have become quite worried about this. So we've added some balanced information from the Asthma UK website, and we've added links to that so that patients and clinicians can be made aware of some of the issues. We also thought about what the professionals needed, what sort of training and motivation they needed. This is a systematic review that we did in part of our development work, where we looked at what other educational packages had included and what seemed to work. Things like using local opinion leaders that would that clinicians knew, basing it explicitly on guidelines. Thinking about, what if you do this, this will happen. If you don't do this, this might happen. So people began to think about the benefits of giving action plans and how it could benefit the patients. Just needing to know how to complete an action plan. Not all clinicians are aware. Actually, it's so simple, and yet if you've not done it before, you're not going to try doing it for the first time with a patient sitting in front of you. You just need to try it out first so that you understand. And the motivational interviewing that is helpful for encouraging patients to adhere to an action plan. So we developed two different modules. One is a very short module designed for the that's the one at the bottom I'm illustrating, which was designed to deliver to a team by a facilitator, and that was designed to encourage the team, and by the team I mean the clinicians, as doctors and nurses, as well as the managers and the receptionists, deliver it to the team so that people can see how they fit into delivering supported self-management. And then there was a more intensive module for the clinician who was likely to be delivering action plans, and very well taken up by the practices. And then there were the organisational strategies, because if it doesn't fit within the organisation, it gets squeezed out. This is some work we did. We went into some practices and we watched how they delivered their asthma care. Basically, what we found was that the nurse was the one most likely to be delivering self-management education and writing out the action plan. Now, she did this in the context of a routine review. Administrative support was needed to invite people into that review. She was the one that was completing the action plan, and she did so. She's in a square box because she's in a room of her own. And she does so following what she does in that asthma review follows a template. And we noted that the asthma action plan was at the bottom of the template. In fact, in one of the routine systems, it was on the second page. So it was a long way down. So she got a lot of other things to ask before she got to action plans. Now, GPs see people with asthma too, but we tend to see them in an acute situation where they're actually wheezing. And obviously our priority is to make them better. So we've got 10-minute appointments. We've got to make somebody who's actually ill, wheezing in front of us. We need to make them better. That's our priority. We know they need an action plan, so we might well refer them to the nurse. When you're feeling better, will you come and see the nurse? But, you know, clearly not all patients do. We don't have time. The clinician, the nurse, the patients don't always go to see the nurse. And so you can see the barriers that we were picking up in the organisation, which is why we were so keen on developing team-based training, because we wanted people in the team to be working together on this. We wanted to improve the template. So we've now got a template that starts with the action plan. In fact, the first opening question, templates are brilliant if you want to fill in a checklist, but the problem is that they can overlook what the patient wants to ask. So the first question is, what does the patient want to discuss in this review? What's their agenda? And the second question is, has the patient got an action plan? And fill that in. So we've altered the feel of the template from a tick jobs to do to hopefully guiding a patient-centred consultation. We've also set up audit and feedback. So by Optimum Patient Care is an organisation that takes routine data from primary care, and they produced an annual audit and feedback report. But they also, for the intervention group, the implementation group, produced monthly audit and feedback reports, and the one with the graph there with the blue lines, that's the number of action plans, and then the attacks going in grey going down. So that goes back to all our implementation group practices on a monthly basis. So now we are in the process of running a UK-wide cluster randomised trial, implementation trial. We've recruited 144 practices, and we are now in the follow-up phase. Basically, the trial design, we're recruiting practices. We are not recruiting patients. No, we've recruited no patients at all. We are just recruiting practices, which doesn't fit the models for governance and research governance in the UK. I don't know about the rest of the world, which is a challenge in itself for implementation science. So we recruited practices and we have randomised them to two groups. One group had this implementation strategy, the whole package, and that package included a facilitator who guided the practice into the components of the implementation strategy that were designed for the patient, guided them towards the education modules and the organisational strategies. And then the control group, who did not get the implementation strategies delivered. We're following them up for 2 years because it takes a year or thereabouts to see all your patients with asthma and to implement the asthma self-management, and then we're following up for a subsequent year in order to see the impact of that. We're using routine data. Because we're not recruiting patients, we want to know patient outcomes. We're using routine data to do this, and our health outcome is unscheduled care. We're hoping to reduce that, and our implementation outcome is ownership of action plans. Now, when we looked at doing this, it's actually very challenging to find out whether people have got an action plan from the routine records. Because it's not recorded consistently, and we were very likely to alter the recording of it in the implementation group practices. So we are actually sending out questionnaires to random samples of patients. So we are recruiting a few patients and asking them whether they have an action plan. We have a health economic evaluation. And we have a very complex process evaluation trying to understand the impact of this implementation strategy within the practices, and we're also, as a little add-on, going to be also interviewing some patients. So we are looking at the process and how how practice is embedded this care. And indeed, some of the issues that we're raising, like within our practices, for example, the asthma nurse leaves, what happens when the next asthma nurse comes in? How do they actually trouble to train her in the impart work? What happens in practices with multicultural, multi-language? How are they coping with it? What about practices working at distances? So we've got a number of scenarios that we're really interested in following up. And whilst we're doing all of that, we are a part of our qualitative process evaluation is to think about the sustainability. How can we plan for sustainability, which is yet another step. So just some take-home messages for you. First of all, really important to distinguish between the evidence-based intervention and the implementation strategy that is going to help embed that intervention in routine clinical practice, and that it is the implementation strategy that's the focus of implementation research. Obvious, really, implementation is at least as complex as the intervention, and I would suggest that often it needs a cycle of development, feasibility testing, refining, piloting and evaluation. In fact, I'd say very often the implementation strategy is probably more complex than the intervention. Think about strategies to address what the patient needs, what the professionals need in terms of skills and motivation, and crucially, the organisation and how that may need to adapt, and how can you fit within the organisational routines and how those routines might need to be nudged to enable something to be implemented. The context is crucially important. It's sometimes out of our control, but at the very least, even if it's outside our immediate control, at least we need, when we're developing our implementation strategy, to work within the context because it's a very strong influence. I showed you translational gaps, but remember that in reality it's a spectrum of trial design, from efficacy through to the pragmatic effectiveness to implementation, and there are other approaches than randomized trials. I showed you the blood pressure one, which was actually an observational study, as well as an implementation trial that we did with the supported self-management. And just a few pointers for the methodology here. Broad inclusion criteria. Basically, you select the population. You don't select patients within a population. You give the intervention to whoever is eligible clinically, not because they want to take part in a trial. As you go along that spectrum of trial design, the flexibility for clinical judgment becomes gradually greater. And with that, of course, you're dealing with more complex patients, perhaps with multimorbidity and other factors. And remember that the outcomes need to reflect the patient perspectives and the impact on healthcare services. And as you move towards implementation, towards population level work, you're thinking in terms of routine data. Otherwise, you're missing data from just the most difficult and hard to reach patients. So thank you for listening. I hope that's been of some interest, and I'm very happy to join in a discussion and answer any questions, and to hear what you're thinking. Thank you.
Thank you very much, Professor Pinnock. Thank you for a very inspiring presentation. We have a few questions coming in, so I'm going to tell you which questions we have. So the first one is from Sabina de Guest.
Okay.
It's how the research pipeline could be strengthened with implementation science methods already at stage 2, T1 and T2. As some issues that might negatively impact successful implementation and sustainability could already be picked up early on. If Sabina, you want to add something?
Yeah.
Please.
Okay. I agree with you, Sabina.
First of all, thank you so much for an excellent presentation.
Thank you.
And very inspiring. Thank you so much, Hilary.
Thank you. I completely agree with you. I think we need to be thinking about implementation right from the beginning. You know, even when you're starting to think about, is this going to work in humans, you need to be thinking, you know, this is going to be expensive. Who's it going to be most valuable for? How convenient or inconvenient is this treatment likely to be? You know, you need to be thinking right the way through, gradually increasing the focus on implementation. It's so often it's left too late. So often people doing the phase 2 trials, phase 3 trials, for example, are not even thinking about implementation. They sort of think, oh, that's somebody else's job. I've done it. I've proved it works. Somebody else's job. I think that's a mistake. I think we should all be working. It's a pipeline. Completely agree.
Thank you. A second question is, could you elaborate on how you have set up your process evaluation in the asthma trial? Which methods have you used?
Which method? Oh gosh, it's quite complex. It's a mixed method. There is a framework that the MRC have produced. The first author is Moore, MWRE. I don't think I put that reference up, which is quite helpful, though that is focused on public health type work, but that is quite helpful. What we did, we set up a logic model. We worked out how we thought our implementation strategy was going to ultimately improve the ownership of action plans and improve outcomes. So we set up we thought through the mechanism of action. We used a logic model. There are many different ways of doing this, but basically we thought through the process. Now, once you've thought through the process, then you begin to see where you can test along that process to see if things actually happened, if that makes sense. So, you know, we needed the clinicians to have knowledge. They needed to know what action plans were. So one of our things that we're testing in the process evaluation is, did they actually look at the education module? What percentage? Because if none of them looked at that, then we weren't going to be getting that knowledge across. We needed to know how many action plans were delivered. We needed, and we obviously are going to have routine data from all these practices because our outcomes on routine data. So we'll be able to look at all these different types of routine data to see how many patients attended, how many patients were called in for a review. Did it increase? We're encouraging practices, for example, to look at the patients, the high risk patients, the people who've had an attack, and call them in for a review. Well, we can pick that up from the routine data to see if it happened. So we worked through the processes. And then we started to, and with that gave us some key outcomes. We had a lot of qualitative work. We are actually doing case studies. So we have got, we set up to 4. We've got, but we slightly changed it because we've actually got 2 in-depth case studies, which we're following right from the beginning throughout the whole 2 years. But we've also got some mini case studies where we're looking at some specific challenges. So we're going into the practices and we are interviewing different people within the practice. We're collecting documents, you know, which action plans did they use? We're talking to different members of the team as to how they changed their behaviour and what they found challenging. So in other words, we've got a qualitative work. We're supplementing that with qualitative interviews from a whole range of other people and practices so that we can try out the theories that are emerging. And we're also going to be talking to some policymakers and because we're interested in sustainability. So it is actually very complex. We have recorded our, I didn't sort of make it very clear that we have facilitation. The facilitator goes into the practice to deliver a workshop, and we've recorded all of those. So we have some work going on with one of our PhD students who is actually looking at what actually happened in those facilitation workshops. So as I say, there was no one approach, multi-methods and quite complex, but it came from trying to understand how we thought this was going to work, the logic model, basically.
Thank you very much. So you are talking about routine data. Do you have to ask permission to ethics committee? How do you manage this?
Oh yes. There's a lot of governance around it, and in fact, that has been very, very challenging. Yes, we are getting. I'll start right at the beginning. We are actually taking routine data, and yes, we do need permission to do that. In fact, we're working with an organisation that does this and produces a quality improvement project under a service agreement, which they've got all the permissions, all the governance permission to do this. They then have the database that we then had to apply for ethics permission to access that database in order to use the data. So yes, it's very complex, but it is challenging because there are lots of different levels. Even if you get national, this is the UK. It's not got this organised, but you have to get national level approvals, but each practice, their data controller has to agree. And we had quite a lot of regions and trusts and practices who said, oh, I don't think you can do that, even though we'd got all the permissions. So it was not easy. It was challenging. But we have managed to recruit 144 practices from whom we have got our baseline data, and therefore we know we can get the routine data, but it is challenging.
Thank you. Before taking the next question in the chat, I'll give the voice to Suzanne Diani, who has raised her hand.
Hello, yes, Suzanne. Thank you so much for the inspiring presentation. Actually, my question is related to sustainability. So I'm really interested to hear your thought about at the very early phases of the intervention development, how can we think of sustainability using implementation science?
Okay. Well, first of all, think about it. Think about how you're going to implement this and how it's going to stay embedded. I think increasingly my answer to that question is work with stakeholders. Right from an early stage, engage stakeholders. Engage the people who have the power. You'll be familiar if you're familiar with stakeholder engagement. You'll be aware of quadrants, and you've got people who are very interested. Some of whom have power and many of whom don't. You've got people who are very powerful, some of whom are interested, but many of whom are not. And the key to this is to find the stakeholders and move people into that top right quadrant where they're both interested and powerful. So it is absolutely around engaging with stakeholders right from the beginning. And those are stakeholders at all levels. Patient organisations are very powerful. So a patient level, working with healthcare managers, working with policymakers, working at all levels, nationally, internationally. You just need to work, and you need to keep going at that. And you started early, and you get them more and more interested. Sustainability has to come to context being supportive of it.
So it's not related to outcome?
It can be. If the outcome is really clear, then everybody becomes very positive about it. But how many interventions are so dramatically effective that everybody says, oh my goodness, that's fantastic, we're all going to do it? Maybe the COVID vaccine and the reduction in COVID is a good example of how things can be dramatic. And there's no question then that most patients, clinicians and policymakers want it to happen. So, I mean, that's an example. I think it is outcomes. I don't suppose anybody on this call is old enough to remember when cimetidine was first introduced for stomach ulcers, for duodenal ulcers. This goes back a very long time. And it was the first drug that actually cured duodenal ulcers. And before that, people were having operations, highly selective vagotomies. If there's anybody on the call that knows what I'm talking about, it goes back a long way. And when that drug came in, it transformed the outcome of the condition, and it really needed no incentives to make that happen, just because it was so blatantly obvious. All of a sudden, nobody needed operations, and everybody's ulcers were improved. But we rarely see that. That's one example that sticks in my mind.
Thank you.
Does that answer the question?
Yes, of course. Thank you so much.
Thank you. There are more questions on the chat. I will take them. But if you want to talk to Hilary Pinnock, just raise your hand and we'll give you the floor. So another question in the chat is, what is, according to you, the best way to know about the barriers and facilitators for implementing an intervention? Interviews, focus groups, or others?
Or all of the above. I think they all have a place. But when you started the question, I was going to say, talk to people and go and see what is happening. I showed you that organizational kind of chart where we worked out what was happening within the practice organization. The way we did that, we arranged some interviews within a practice, 2 or 3 interviews in the practice, but my researcher went into the practice with a large bag of sticky buns, carrot cake or whatever, and she sat in between the interviews, she sat in the common room, and every time anybody came in, she chatted to them. And she did lots of little interviews, she heard lots of information. So in other words, be there in the practice, observe what's happening, and get to see the routines, listen to people, listen to a range of people. Sometimes interviews, focus groups, I mean, qualitatively, they have different values, don't they? Focus groups allow people to bounce ideas off each other. But it also can be quite intimidating. Not everybody wants to speak in a group or to say something that they think might not go down very well, whereas they might say it in a face-to-face interview. Face-to-face interviews don't get the benefit of the other conversation. I tend to try and do both.
Thank you. It's striking to see how much your research is in daily practice. I think that's probably a strength of what you're doing, is to be able to do research and being in the practice.
Yes. Yeah, I agree. I mean, this research comes from what I am doing in my clinical work. The questions, if you like, come from within the clinical work, and because I understand the clinical context, I can talk to colleagues. I can work with colleagues and the clinical setting because I understand it.
Yeah,
absolutely crucial. You can't impose something on a system you don't understand.
Yeah, thank you. Dennis said it's a great presentation. Congratulations. And Dennis has a question. Do you want to ask your question or should I read it? I'm going to read it. I'm interested in Dr. Pinnock's thoughts on conducting implementation research in resource-challenged communities, geographically isolated, disadvantaged, and conflict-affected areas. Would be the key points to consider? What would be the key points to consider given this kind of contexts?
Yeah, absolutely. And I've been involved, I didn't talk about it here, but I have been involved in the Respire Global Health Unit, and this is exactly what we are doing. We are implementing, doing implementation research in lower middle income countries, particularly Bangladesh, India, Malaysia, more recently Sri Lanka and Indonesia. And so this is exactly what we're doing. I think the rules are the same. Listen to what is going on. Look, and I'm not doing it. I'm supporting the people on the ground to do it. Listen to them. Listen to what their problems are, listen to what they can do, listen to the limitations, listen to the advantages that they've got, and work with that. It's exactly the same as you have to do in any implementation research. Okay, so the solutions will be different. That may be the case, but the principle of listening and then adapting your intervention. So the example that we're working on, we've been doing a lot on recently, is pulmonary rehabilitation, which is enormously effective intervention. an excellent evidence base, but one of my colleagues from Bangladesh, a community-based physician in Bangladesh, said to me when we started the Respire work, he said, well, do you realize that all those studies in that Cochrane review that says it works, almost all of them are for high-income countries? And he said, I can't do this, I can't do that. What should I do? I want to do pulmonary rehabilitation in my setting. So he actually did a PhD and did a lot of work on this. He's put together, adapted what needed to be done. If you haven't got the sophisticated technology equipment, but you have got steps, you can step people up and down to do their exercise, find a way to do the exercise. And we've worked through feasibility study work with him. We've done some pilot work, and we are just about to embark on a randomized controlled trial looking at delivering pulmonary rehabilitation in a low resource setting to people where the diagnosis may not be completely clear because they haven't got access to CT scans or whatever, but they've got a respiratory condition, and pulmonary rehabilitation would improve their functioning. So we're taking a very, very pragmatic view from a low resource setting. How did we do it? We listened and we worked and we adapted. Does that answer the question?
I think so. Thank you. Another question from Gemma. Does Gemma want to ask the question?
Yes, hi. I'm okay if you read it either way, whatever's easier.
Yeah, can you ask your question?
Sure. Sorry, I can't turn my camera on for some reason. Or maybe it's on, I don't know.
Yes, you can.
Oh,
I do hope before we finish you will all put your cameras on, because I really would like to know that there are people behind the names.
Thank you so much for the presentation. I am doing my PhD in primary healthcare, and so I suppose my question is more framed from an academic perspective. In terms of theoretical frameworks, this of course fits in very well with the normalization process theory. Yes. And I just wondered if there were any other frameworks that you suggest looking at.
Yes. MPT, I've used normalization process theory, and that does have some value. If that's what you're using, you'll also find there are some things that don't quite work. You know, if people if they've been trying to do something for a long time, they can't look back far enough. If they have no other concept, they don't know what, you know, if it's too early, they haven't really got a concept of what could happen. So we did have some trouble with normalization process theory, but I do think I've used it and found it quite helpful. What I do find helpful with it, if you're using it, Gemma, and you want to try this, online, you can go online and use their online tool where you've got the 16, isn't it?
Yes.
Different parameters. And we've done that with a group and asked people to actually discuss it, almost like a focus group, with using that as a prompt. And it's really interesting how the discussion, did people appreciate it? It was different. And it's interesting how you get a really good discussion going. So that is good. There are other frameworks. I mean, for some of particularly the contextual stuff, I think it's really quite helpful. CFA is quite a useful framework. That's CFIR, Consolidated Framework for Implementation Research. In terms of outcomes, we often use REAIM. That seems to be or one of the similar ones. Which encourages you to look not just at whether something's working in effectiveness, but also at the reach, and how people adapted things. So there's a couple that I've certainly used. We're not sure whether to use MPT, normalization process, in the analysis yet for IMPART, but it's one of the ones that we're thinking about.
Thank you so much.
We're also using IPARIS for the theoretical underpinning there, which may well give us something of a framework, because that looks at facilitation. So it depends what you're doing, really, doesn't it?
Thank you. I have another question. You talked about complexity quite a lot. So because the context is complex, doing implementation research takes time. So, but often people want to go fast, or institutions or policymakers want to go fast. How do you get along with this issue?
Well, I don't know really. I mean, it is complex. It does take time. I mean, if you looked at the dates on some of the papers, some of the early developmental papers go back to 2014, 15. And then we've had a program grant that should have been 5.5 years, but's turned into 6.5 because of COVID, which held it up. So, it has taken a long time. Having said that, we have published a lot on the way. So although the trial is going to be another year or two yet, on the way, we have published a great deal of data. So, we've got information and knowledge coming out all the time from qualitative developmental work, but the trial will certainly take longer. Yes, we had quite a substantial problem with this, with the telescoped work, the blood, not so much the blood pressure, but when we used it for a COPD telehealth trial, the trust, NHS Lothian, had got the equipment and they wanted the trial to start tomorrow, and we had an awful lot of trouble saying, well, actually, we're going to do this as a trial. We do need to set this up. It's going to take us 6 months, 9 months, 12 months to get all the permissions. And they were sitting there with all these boxes of equipment in a store saying, well, use them tomorrow. So, yeah, there are challenges.
Yeah. Thank you. Suzanne?
Actually, I have a question a little bit in the opposite direction of your question, Marie. So sometimes when we do implementation science work, we're seeking impact, right? And impact sometimes is an impact not only on the patient directly or the practitioners, but also at the policy level, because we are looking at some kind of transformation in the healthcare.
Yes.
So, and therefore, sometimes stakeholders are hesitant to go big or fast. They want to go slow. So they require that you scientists do a magic, do some kind of piloting or feasibility in their own words, and then come out with the result. And then they will say, okay, let's then go full-fledged with the program or the intervention.
Yeah.
So how can we reconcile science, implementation science, with such kind of community complexity?
Well, yeah, I mean, I don't know the answers to that, do I? Except working with stakeholders. And you've got to grasp the moment. There's a right moment for stakeholders to implement something, and there's a time when they're not ready to do it. And that usually, being a bit cynical, probably refers to where they are in the political cycle and when the next elections are coming up. Because if you've got an election coming up, you're going to want to behave differently to if you've got 5 years to try something out and change it if it's wrong. They think in terms of a very different cycle, but you have to work with them.
Yeah.
and engage them. Key people.
Thank you. Any other questions from the audience? Either by chat or by unmuting you? I have maybe a final question to ask you, Hilary, about how do you work with your team? How do you teach the young generation implementation science? And how do you secure the money for all the research you are doing?
Well, the money, I mean, the two trials that I've shown you, the two studies, the hypertension one, actually, most of that was NIHR, that's National Institute of Health Research money, and certainly IMPART is funded by the National Institute of Health Research. So that's UK money. The other thing, just to broaden your question, however, you were talking about teaching it. One of the things that we have tried to do with all these major projects is that we have tried to involve PhD students in the project, aligned with the project, because often it's possible to find a pot of money for a PhD student. I mean, certainly the university will often provide, offer one if you like. If you ask, you can get a free PhD student to go along with a big grant that you've brought in. So what we have done is very explicitly put 3 PhD students alongside the Impart programme, for example. One has already got her PhD, and Nazim is halfway through, and Barbara. So we've got 3 PhD students who are working on projects that are aligned with it. So they're embedded within within our work, so they see how implementation science is working, and they're doing their own PhD projects. We also have a lot of small projects, so we've always got master students and undergraduates, and we bring them in to do projects. So for example, with the process evaluation data, we have got a huge amount of process evaluation data, and we've had, for example, visiting PhD students or a master's student, for example, looking at the how the education modules have been used, and they've been able to go into all the detailed usage data, how our Living with Asthma website, usage data on that, and they've done work on that. So we've involved them, a large number of people, we've involved them in this, and hopefully some of them go away enthusiastic about the concepts of implementation research. Certainly the aim.
Thank you very much. If there is no other question, I think we are coming to the end of this session. Professor Pinnock, I'd like to thank you on behalf of Impact Group. I would like to thank you very, very much for this very inspiring talk. You shared with us a lot of experience, a lot of data, and I think we had a very nice talk with you. Many questions came in. So thank you very much for your presence, for being with us remotely. And maybe we'll have a chance to meet you once in Switzerland.
That would be lovely. I'd love that. Thank you so much for inviting me. I've enjoyed talking about something that I feel passionate about and I enjoy doing. So that's wonderful. Thank you.
Thank you. Before closing the session, I'd like to introduce the next webinar. The next webinar will be on the CFAR. Professor Pinnock, you talked about CFAR before. So the next webinar will be about the Consolidated Framework for Implementation Research 2.0. And we will have here Professor Rogel from the University of Pittsburgh and Professor Dan Schroeder from VA Michigan. And this is going to be, I think, on the 15th, November 15th at 5 p.m. European time. So be with us for this last webinar 2023. I'd like to thank the audience. I'd like to thank all the people who asked questions. And I'd like to thank the Impact team for a wonderful webinar. Thank you very much to all, and see you soon again.